Welcome to this afternoon's GSA and Link AD webinar. My name is Jen Pettis. I'm the Director of Strategic Alliances at the Gerontological Society of America. Our program today is use of different research designs for developing, evaluating, and implementing person-centered psychosocial interventions in dementia. And I'll just go over a few housekeeping things with you. Please introduce yourself in the chat. We'd love to know who is here and where you're joining us from. Our guest today is all the way from the Netherlands, so let her know where you are. Our conversation is being recorded and it will be made available on the GSA website. We also will make the slide presentation available as a PDF handout there for you as well. Please keep your video off and your audio muted until it's time for discussion. And we do just have the chat box. We don't have a separate question and answer box. So should you have any problems with technology that we might be able to help with or questions for our speaker, please go ahead and put those in chat. And I want to remind you that this is the second in a series of 3 webinars. And so please join us again next week for the third of those. And if you missed the first one, it is available on the website. And before I turn it over to Cheryl Zimmerman to introduce our speaker, I want to remind you that GSA 2023 is in Tampa, Florida, November 8th through the 12th. You still have just about a week from today to get your abstracts in. The submissions are open right now, and actually registration also has opened on our website, which is gsa2023.org. Check it out and take a look at the beautiful hotels. They're right on the water. It's like going to a resort this year. So it's going to be the place to be in November. And I say that to you from a snowy New York State. So looking forward to it. And without any further hold up, I'm going to turn it over to Cheryl to introduce our speaker and tell us a little bit about Link AD. Take it away, Cheryl.
Thank you, Jennifer. Indeed, yes, I'm here representing Link AD, who is co-sponsoring this webinar. Link AD is the shorthand term for leveraging an interdisciplinary consortium to improve care and outcomes for persons living with Alzheimer's disease and dementia. It's an international network intended to promote psychosocial research to achieve better outcomes for people living with AD and their caregivers. This is funded by an NIA grant to the Alzheimer's Association. Sam Fazio, the Senior Director of Quality Care and Psychosocial Research, is the project director. And I'm from University of North Carolina, Chapel Hill. I'm the research lead. On this slide, you see the aims of Link AD. Briefly, they're to review existing outcome measures and care tools and identify gaps, to promote the development of new outcome measures and cure tools to fill those gaps, and to facilitate the dissemination, adoption, implementation, and sustained use of existing and new outcome measures and cure tools. So it's really all about using research to improve care and outcomes. Some of the key initiatives and the benefits of joining the Link AD network are on the left-hand side, and we've got just a few here. One is that we have updated and ongoing calls for papers on psychosocial measurement in the journal Alzheimer's and Dementia Translational Research and Clinical Interventions, TRCI. So if any of you who are listening have papers you feel might be a good fit, you'll want to check that out. TRCI, and you can also contact myself or Sam Fazio. There's also grant funding opportunities for the Alzheimer's Association. They've put forth a special RFA for the last 2 years running on advancing research on care and outcome measures. The shorthand term is ARCOM, A-R-C-O-M. So you should be on the lookout for that. It's specifically relevant to the work that all of us do. And then webinars such as today, and of course, other networking opportunities. So if you're interested to join the Link AD network, our website is alz.org/linkad. So I'm really thrilled you're here for today's webinar because it highlights the international nature of the Link AD Consortium. Our presenter, as already said, is from the Netherlands, Dr. Maud Graff. She's a professor of occupational therapy at the Radboud University Medical Center, an honorary associate professor at Nottingham University. And her research is focused on the development, implementation, and evaluation of interdisciplinary psychosocial interventions to improve care and quality of life for persons with dementia and related conditions interventions. She's received numerous scientific awards and several grants from Dutch and European healthcare funds and ministries, and has served as a journal editor and a member of several international boards and advisory committees. So after her presentation, we'll have time for questions, answers, and discussions. If you have questions while she's speaking, please put them in the chat, and then we'll discuss them at the end. So for now, Dr. Graff, I thank you for joining us and to present use of different research designs for developing, evaluating, and implementing person-centered psychosocial interventions in dementia care.
Well, welcome everybody. I'm Professor Graff. I have a chair in occupational therapy at the Radboud University Medical Center in the Netherlands, and I work at the Rehabilitation and Scientific Institute for Quality of Healthcare, so the rehabilitation department, which is more a practical department with also research aims, and the Scientific Institute for Quality of Healthcare. And I also, I'm in the board of the Alzheimer Center of the Radboud University Medical Center. Thank you. I would like to present today different research designs we used for developing, evaluating, and implementing person-centered psychosocial interventions in dementia. And I will apply this within the MRC framework. So you will see the framework, and in each phase I illustrate this with several interventions we developed and evaluated and implemented some of them. And we see then what research designs were used. Next slide, please. Well, yeah, I put this in because it's normally asked to me to say if I have some disclosures, and well, it's all kind of funds we received for the research. Next slide. Yeah, I would like to start with the characteristics of person-centered care, because it's important to have that in mind when we look at the research designs and what data we collect and how everything has impacts on outcomes. So if we look at the person-centered care in general, then you see that it's characterized by attention, patience, respect, dignity, autonomy, motivation and passion and quality of life of people with dementia and their caregivers. And we focus then on the personal needs and wishes of those people, but also on the context. And that is important, because that is also one of the factors that is of influence of the outcomes of interventions, but also all these individualized characteristics. And for this, I would go to the next slide, please. Yeah, so if we look at person-centered psychosocial interventions in dementia, then we see some of those aspects back, but we see how we intervene, and we intervene with many interventions that we are focused at. The central aspects of the interventions are the respect and the dignity and the reciprocity of people with dementia and caregivers, and to support the self-determination and autonomy of those people. And we start with their motivations, their needs and wishes, and their life story for both the person with dementia and the caregiver. And their idea about what is meaningful daily performance, and how they are able to be resilient, or what aspects are that are disabled to have really good resilience. Next point on this slide, yeah. So also the context, and that is one important aspect, and we will see that back in the MRC framework, which I will present. That is not only the physical and social context of the person with dementia and the caregiver, but also the interprofessional context of the disciplines that support those people in psychosocial interventions, and also the societal, political and economic context, which should be taken into account when implementing and evaluating these kind of interventions. And if we look then to the routines, then there are a lot of routines, not only people with dementia make use of routines and caregivers, but also professionals. And it is very hard to change professional working and professional performance, and that they adhere to new ways of working and adhere to guidelines. So that's all aspects that are of influence of outcomes and of implementation of these interventions. Next points, bullets, please. Yeah, and then one of the big things is that we work together with people with dementia and the caregivers as therapists, as social workers, as medical doctors. But here in psychosocial interventions, we focus on their individualized goals, which can be flexible and which can change over time. And the person with dementia and the caregiver are equal to the professional. So it's important to know that also for development and evaluation, people with dementia and caregivers should be part of the process. And yeah, everything is focused on the participation in society of people with dementia and their caregivers and their well-being, quality of life, and positive health. Thank you. Next slide, please. Yeah, here I make just an overview of the phases of the MRC framework, and I think most people know this framework, which was published in the last version in the BMJ in 2021. And you see here that there are the phases of the development of the intervention, the feasibility, the evaluation, and the implementation. But in all phases, the core elements of the context should be taken into account. And I will illustrate that further on in my presentation. Next slide, please. Well, if we focus on, if we focus on the phase of development, then we see that in the MRC framework, it is written that's important to base the interventions on the evidence. And that is the evidence for intervention components, but also for theoretical models, but also the practical evidence, which is perhaps not all published yet. So for developing intervention, it's important to look into literature, but also to make use of practical experience of stakeholders and to look up underlying theoretical models, or to see how mechanisms and context and outcomes are related in theories. And also, it is important that we take into account the context that I already mentioned, the intervention process, and that we find out in this phase what could be success factors and successful components of the intervention and of the implementation. And if you see then the core elements, then you see that it's important that if we have all this information, that after the phase of development, we develop and refine our first theory, program theory, based on what we found, and we refine the intervention. But also that we engage the stakeholders about what their experiences were with the intervention and how we can improve it, and that we identify key uncertainties which are in the can be in the professional and in the people which we don't know, so that we go by interview or focus groups to get insight in that, or by observations, but also in the context. And then it is about the societal and economic and political context, but also the social context of the people themselves. Well, if we go then on to the next slide, then I would illustrate this with a DOMA program, which is Dutch and which is in English called the COATED program, Community Occupational Therapy in Dementia program, which is one of the psychosocial interventions I would like to make use of. And I would also illustrate it with another intervention. Please go to the next slide. And that is the occupational therapy and Parkinson's disease intervention, which was partly based on the coded occupational therapy and dementia intervention, but was specified for this target group. And for both interventions, first the program was developed and also guidelines and theoretical backgrounds and models were found in literature, were collected and were described in a book and were translated in several languages. Yes, please, next slide. Well, if we look at the development of those programs, then we see that in both development of both intervention programs, we made use of a working group of stakeholders. And they came from all kinds of fields, but they had expertise on one of important fields. And with them, we started with the needs formulation and getting a picture of the societal context and the practical context. And also we looked up in literature for interventions which were there, components of intervention which could be useful and successful and underlying theoretical models. But we also consulted experts for this information. And we asked also to stakeholders in practice about their practical experience with those kind of interventions. And based on that, we had consensus rounds and we made a draft intervention. Accordingly, in this phase of development, we explored this in practice and we made use of qualitative research, thematic content analysis to see what prerequisites for implementation were needed, what is important in treatment development, what barriers played a role on all levels, and what success factors and mechanisms for implementations would play a role. But also we looked up for successful components of the intervention and what should then be outcomes that and outcomes and what should then be that should be evaluated in future research. And we refined the intervention and defined implementation prerequisites and strategies. Next slide, please. Well, theoretical model, that was our model of human occupation, where you see all aspects which are important in occupational therapy and to improve occupational performance. We call that is meaningful daily performance. We call that occupational performance. Next slide, please. And the other model here, you see how the person, the activity and the environment, how they work together and where you really have meaningful daily performance, where the personal aspects and the personal characteristics, needs and wishes, and the activity characteristics and the environment aspects are in good company, and then in the middle you see the meaningful daily performance. That's the other model. Thank you. Next slide. Well, and then you see the occupational therapy and dementia program in the community was focused on people with dementia and their caregiver, that they can participate in meaningful daily activities, deal with the consequences of the dementia, have more self-confidence and better quality of life. Next slide. And the caregivers, that they improve their sense of competence, autonomy and participation in their own meaningful activities and not only give care to their relative. And also the decrease of burden of care and their better quality of life. Next slide. And then here you see an overview how that intervention looks like. So this needs and wishes, which is of the person with dementia and the caregiver, which is the start. And it starts from the stories of all those people, and then also the stories by observations and interpretations of the OT is added. And that together makes the picture of the problem or the needs definition. And then in goal setting phase, people have a negotiation to get shared goals or to choose for separate goals where everybody is happy with. And then the intervention plan is made, and both the problem solving of the caregiver is trained and the empowering of the caregiver and adaptations of the environment are made. and then the effective use of strategies of the person with dementia in that adapted environment, and with those empowerment of the caregiver cues will take place. And we also focus on the person and on the caregiver itself, so the caregiver, her or himself, and that their care and their own activities and quality of life is in balance. Next slide, please. Well, if we look at the Parkinson intervention, it is based on this coded intervention, also narrative interviews and observations in person, activity and environment, and shared goal setting and treatment plan. But the treatment plan is focused also on all the needs of people with Parkinson's disease. Next slide. And yeah, it is the focus is to improve insight on and self-management and daily performance and other ways. And here also the person, him or herself, can optimize daily routines and adapt strategies and ways of performing when they have a no or mild cognitive impairments. And also environmental aids are used. And the caregiver gets information and is also trained in skills and coping. Next slide. Well, if we see here, and we come back to all the research designs we used for those two interventions, then you see that for intervention components, theoretical models and outcomes, we made use of literature review and Delphi rounds, but also of practical experience. And that is considered in the core elements. Here we see that focus groups and individual interviews were used, but also the needs and success factors and barriers were analyzed in interviews and focus group by qualitative research, and all implementation prerequisites and implementation strategies that people advise or recommend that should be used, or which were barriers in this case. And also we looked up in the case records of successful interventions, and we looked what were then the most successful components and aspects of the intervention, because that would be then, and what would then be the outcome, because that would be then what we should measure in future feasibility and evaluation research. Yeah, we also made use from participatory action research in the Parkinson study, and we made use of interprofessional learning practice, where they focused on how to use those guidelines and interprofessional collaboration in different contexts and what should be approved. And that is a kind of quality improvement circles where you go on and on. And the same we did for coded, but not exactly participatory action research, but we also discussed and improved all the time the intervention when exploring. Next slide, please. Well, if we then go to the feasibility phase of the MRC framework, then it's important to assess and test and pilot an intervention in practice, and to test and pilot implementation, and also the research design for future evaluation. And also for this phase, it is important to take into account the core elements and consider the context, and that we afterwards refine the program theory based on what we find in this phase, but also the intervention itself, and that we take into account all the context factors that can play a role, and that's not only the economic but also the political and the interprofessional and societal aspects, and that we get more insight in the key uncertainties. I have difficulties with that word, and that we engage all the time also the stakeholders, what their experiences are, which are the people with dementia and the caregivers, but also professionals, managers, and everybody around. Next slide, please. I will illustrate this with our quoted and OTIP study. Here we made use of two pilots where we did the process and evaluation of the implementation and of the intervention components, if these were eligible. But we also evaluated the change over time with the measurement instruments we chose. And we looked up if these were sensitive for change, these measurement instruments. And also we looked if the conceptual model still could be our model. So the theory, if this stands after the feasibility phase. And the conclusion was that our quoted and OTIP intervention was both were feasible. And both studies we triangulated our qualitative results, which were the experiences and out of the interviews and focus groups, and also what we found in the case records of the therapists, with the quantitative findings of before and after measurements. And so the limited effectiveness we there evaluated. But we also evaluated the recruitment, the acceptability, and the implementability of the intervention. And recommendations were that the recruitment strategies should change because the general practitioners were not the good referrers for occupational therapy. It were the elderly specialists and the geriatricians, but more and more it were the home care nurses and the other allied healthcare professionals. In both studies, the primary outcome measures were feasible and sensitive for change and showed positive changes. And they were good to use, so there were no burden was reported by the participants, and they had positive experiences with the intervention and the research design. In the quoted intervention, we explored that also the caregiver could be interviewed by telephone for one of the instruments. And for the OTIP intervention, we saw that the measurement instrument we chose as primary outcome, and the primary outcome measure should better be secondary outcome, which was in a first case, it was the process skills, and we later on chose for the performance skills and the how do you call it, the fatigue of people with Parkinson's disease, what was more important, and so we chose that as primary outcomes. We also saw that the training of the OTs and of the research assistants should be improved. So this is what we did in the feasibility study, and that is published as well. Next slide, please. Well, then you see here in how that looks like in research designs. So we did triangulation of qualitative, we had mixed methods, qualitative and quantitative research. And we triangulated the qualitative and the quantitative data to the theory, the underlying theoretical model. And we made use for the feasibility aspects of acceptability, demand, and implementability, and limited effectiveness for, of the model of Bowen, which was published in the BMJ, and also the MRC framework, which talks about the recruitment, those, and also those aspects. But Bowen is a bit more specific. We also looked at the context. So in participatory action research, the interprofessional working was evaluated. We didn't do that for the quoted in all the phases, but for the OTIP we did that. And for both, we looked into what happened in practice and what and if professionals were able to perform those intervention components, and what remarks they made on it, and what were their learning goals, etc., which they made notes on in their patient records. But also we did interviews, and so we looked at case records, we did interviews and focus groups, so that should be placed at process evaluation. where we looked at the intervention, content, delivery, and implementation, and also how the research design was experienced. Well, next slide, then I go over to the evaluation phase. Well, here you see again the core elements, but in the evaluations phase in the MRC framework, it is said that you should use the appropriate methods and to evaluate the successful, the successful tested intervention. So after the feasibility phase, you look up what is then best in this case, in this context, in this population, in this research, what method you should use. So it's not just the RCT, and I will show that because in our studies of the OTIP and COTIP we did that, but in another study which I present as well, it should be better to use another method. Next slide, please. Well, we made use of a randomized controlled trial for the COTIP study, which was published in the BMJ for effectiveness and cost effectiveness, and both it was effective and cost effective. Next slide. And here you see where it was effective on and cost effective on. So the daily functioning of the person with dementia, sense of competence of the caregiver, and the quality of life, mood and health, and also cost effective were cost savings. Next slide. In the Parkinson study, we also had effectiveness and cost effectiveness, but no cost savings. It were equal costs. And this was published in the Lancet, the effect study, and the process study was published in the movement disorder study, and we also published in clinical rehabilitation. And here you see which lessons we learned, because although it was significant and clinically clinically relevant improvements we found, and it was effective, we saw that in mild and severe dementia, therapists didn't make use of the right strategies that were defined in the guidelines. So they were focused on the group that had mild to moderate Parkinson's disease, and they were used to that group. And they felt insecure when they had to treat people with mild Parkinson's disease or severe, and they didn't fully use the guideline. And we saw that they also could make better use of the collaboration with the caregiver and the interdisciplinary team. And therefore, our conclusion was that we need to improve our occupational therapist professional performance for those two groups, and also for the collaboration, because then it could be more successful and we could have a higher impact, although we already had good results. Yes. Next slide. And here you see that in the Parkinson study, the performance and satisfaction in meaningful activities improved, and that was a client-centered outcome. And the cost effectiveness, there were savings, on the costs for admission in hospital, but no additional costs. Next slide. And if we look at the OTIP process evaluation, that's what I just discussed already a bit, is that the quality of the occupational therapy intervention was no good. It was not sufficient. It was partly, it was sufficient, but it was not good. So partly they made use of the guideline, but partly they didn't use it for full. That the effect of the intervention was dependent on the number of treatment sessions they made use of, and also if they could timely deliver aids, because that is in the Netherlands a problem, that aids for mobility or for other things, for work, that it takes a lot of time to have them in the home environment, and then therapy cannot make use of that. Yeah, the collaboration and interdisciplinary network was a point that could be improved, and also the collaboration with the informal caregiver. Next slide. Well, if we see here then the mixed method research designs we used, then we made use of effectiveness and cost effectiveness study, the randomized controlled trial. And we made use of the process evaluation of the monitoring diaries and records of stakeholders and of interviews and focus groups focused on the treatment delivery and the social, political and economic context factors. Next slide. Yeah, here is another intervention which was based on the COTID, so the Community Occupational Therapy and Dementia program, but also the Physiotherapy Coach to Move program, which is a self-management program at home, and welfare support. And here we made use of the successful components of all three programs, and then in kind of practical community, so an interdisciplinary practical community, people explored what was the best way to make that fit in a guideline, in an interdisciplinary guideline. So we developed an interdisciplinary guideline to improve social participation, and this was called the Social Fit program. Next slide. And here we saw that it was feasible. So in our feasibility study, we found positive changes after the social fit. So our outcome measures were sensitive for change. We found positive changes. And also the recruitment and the acceptance was good for the group we included. But when we started the randomized controlled trial for the evaluation phase, then only some people participated. So we had a very small group, and we couldn't do a randomized controlled trial. And therefore we did a process evaluation, but also additional qualitative research. And we found that there were a lot of social barriers and social stigma, which played a role. And therefore people were afraid to participate or to improve their social performance in society. And what also came out from the side of the professionals, they found the intervention was too complex. It was not always clear who started. Was it the occupational therapist or the physiotherapist? And what was the role of the social worker was not always clear. And who had the lead and how. Yeah, it was all described that they had together make a goal settings plan, and they had to discuss and collaborate on the goal setting and the treatment plan, but it was too complex. For the people, they had a fear. And the fear, which was to go out and to go in society and to be confronted with their cognitive impairments. And they experienced social barriers and social stigma in society. What we saw is that people who participated, some were really ready for change to go out in society and really work on social participation goals. But others, because of the occupational therapy environment, who started in the at the home situation around the house, people stayed around the house and didn't focus on social participation goals, but on daily performance goals. And they were very satisfied with therapy, but yeah, social participation was not reached. And part of that group, they reached later in time social participation goals, and so they needed more time to get ready to go out in society. So we concluded that for a design, perhaps better a stepped wedge design could have been, because then you can make use of when people are, of different moments in time when people could be ready to go out in society, and you could base that on client characteristics, which is difficult, but that should be a way. Another way could be a lot of NS1 designs, where a series of NS1 designs can be used, that we get insight in what really happens there in the intervention, but also how does improvement work on social participation, and that we can make perhaps different profiles of people. Instead of a randomized control trial where everybody starts at the same time and ends at the same time, and nothing can be changed over time. Also, one of the things what came out was that there was insufficient social inclusion and participation from the social network, which could be improved. And therefore, we decided to develop another project where we would work at the society side, at the dementia-friendly society side, which was another project, which is on the next slide, please. And that is a project where we focus on the social inclusion and participation of people with dementia from the society side. So how dementia-friendly communities can be developed, and what are the characteristics and the successful components, success factors, and underlying mechanisms and outcomes of dementia-friendly societies. For this research, we made use of the realist approach, and we made use of the realist review and the realist evaluation, and we piloted it. So next slide, please. Here can I show what we did? Well, when you make use of the realist method, then at the top, at the surface, the context and the intervention is part of the context, and the outcomes can be seen, or people talk about that. But what mechanisms made that an intervention or a society, a dementia-friendly society, is really dementia-friendly or not? What makes it successful? That are the mechanisms, resources, and responses that you get. And that is important because that is underwater. So it is very important to perform then more deep qualitative research to get those aspects on the surface and to get insight in how this works out. So how the context, mechanisms, and outcomes are related, and how they how the theory behind successful dementia-friendly societies is. So this is research where we develop theory of change. And what we did was, in literature and in practice, a review. So we reviewed what were outcomes and context factors, and if there were mechanisms described, we made use of them as well. So we try to make first theory, but we also get that out of multiple case study of best practices, so successful cases in the Netherlands and the UK. And based on that, we refined our theory of change. And then we made a framework and a first draft idea of some theories of change on different levels, which we tested out in pilot communities, which would become dementia friendly. Next slide. Well, if we put this all together in our research designs, in our mixed methods, then we see that our feasibility and evaluation phase are changed. And you see that in the so for both the feasibility and evaluation phase, in the core elements, we made use of the realist review information, which is on the context, underlying mechanisms, and the outcomes, and how that is related. So the theory on that, how the change would work out. And we also made use of the realist evaluation, which is at the side of the evaluation phase, where we refined the theory and based on our practical experience, and we adapted that and made new context, mechanism, outcomes, theories of change. Well, now I finished the evaluation part, and I would go to the implementation part, which we did also in the COTIT and OTIP study. And in the MRC framework, it is described that it is important to improve the uptake and the impact of successfully evaluated interventions by implementation. And therefore, you need to do research to explore in pilot implementation research what implementation strategies are needed, what should be prerequisites, how should implementation be rolled out, and then also implementation could be evaluated in that phase. And I will illustrate that with our interventions. Well, in the Parkinson study, it is implemented now in routine care and in Europe, but the evaluation is running. So, but you can see that it is also in Norway and in Luxembourg and France and in England and in America rolled out. Next slide. And the COTIT intervention is implemented in routine care in a first study, which was insufficient implementation. And here you see what were the facilitators and the barriers. Facilitators were that there were not enough referrals to COTIT intervention, to occupational therapy at home, which was really new at that time in dementia. So all the therapists were all the time working on getting more referrals and focused on that instead on delivering the intervention. They felt after a period of time, they felt unsure about their qualities of that intervention because they hadn't enough time for implementation, and they didn't feel confidence. There was a problem that they needed to have more coaching on the job to feel more secure, but also to get more experience. And well, there were financial resources, but sometimes that was not enough. That was 10 hours a year. And at the moment, it is 2 times 10 hours a year, because you can get 10 hours a year for the caregiver and 10 hours a year for the client. And what they missed was the regional groups where they could discuss and learn from each other, and which were not, they started up, but they were not experienced at that time. Next slide. Well, now we are in different places in Europe as well, and we implemented it, and we also worked on the implementation in the Netherlands. Next slide. And yeah, here you see the translation in English, which is not a book, but a research manual. And in French and Italian, it are books. Next slide. But there also, we learned a lot of lessons about the implementation in routine care in Europe, because this was running at the same time as the implementation in the Netherlands. The first one of that, and the other was later. Well, in Germany, in the Netherlands, it was insufficient, but it's now good, and I will present that later. In Germany, it was also insufficient, and here the intervention didn't fit to the culture of the German culture, because they were not used to work so person-centered, so it didn't fit to the education level of the therapist, but also the outcome measures were used in a different way, like need for assistance. People don't say they have need for assistance, but it were the same people with the same cognitive problems, so they had need for assistance. In the Netherlands, we say that, we have people that they had need for assistance. In Germany at that time, they said, no, we don't need assistance, because they wouldn't have assistance. But then you have a difference in outcome, and we had a ceiling effect on that. But also, there was the therapists were not used to work in a client-centered way, and the healthcare system was not based on that way of working. So it was difficult, the implementation. In the UK, implementation was fair, but still not optimal. And we also, like in Germany, didn't find significant outcomes, because also implementation barriers and a lot of factors played a role for those outcomes. In Italy, we found good prerequisites. And here, one example here is that all professionals and all disciplines were connected to the implementation. So they were invited to the occupational therapy training courses to have information on that. They were really working together, and also cultural norms and cultural and healthcare in the region we implemented in Emilia-Romagna were very good. So they were very open to such client-centered and emotion-oriented interventions. So here we published the first implementation and pilot studies. Next slide. Well, implementation in routine care in the Netherlands in 2020 is now good. We have sustainable implementation quoted in the Netherlands. Over 800 OTs, and if you know that there are 3,000 OTs in the whole of the Netherlands, then over 800 trained who are focused on dementia, because we treat all kind of diagnosis and patient groups. Then that is a really big group. It is the first course which should be followed when you treat people with dementia in the Netherlands. And we have also a website now where there is search for a coded OT, where referrals and also caregivers can find OTs that are trained in this intervention. And the expertise of the OTs is improved because they get a lot of referrals, it's more well known, and they get all not only the training and the skills training and the feedback on that, but also the feedback at the workplace, so coaching on the job. And they get that 3 times in half a year. There are now good networks, so interprofessional, and there is also a local and a regional interdisciplinary situation where other disciplines think about the OTs, except the general practitioner, because in many cases they don't know, and there are networks where they are included in, and there they refer. But it is in many cases that other disciplines talk to the general practitioner, and then they refer, or that caregivers come directly, or that people come directly to the intervention, which is possible.
And Dr. Graff, I'll just give you a time check here. We've got about 8 minutes left, and there were 3 questions in the chat. So just so you know.
Yeah, I can finish here. Yeah, okay. Well, they take the last slide, and you see, go to the end, please. Yeah. And here you see, this is the normal model, but one back, then you see, what we did. Okay, and then the last slide is perhaps nice because that is the model that is published in the BMJ of the MRC framework. What you should do, but how you should do, is not published, and that's why different research designs can be fit in all those phases. Yeah. Thank you. Well, questions?
Oh my goodness. This was a tremendously rich presentation. You touched on so many things, really the whole series of doing research across all the different research designs with so much depth. But I'll just jump right into, there's 3 questions. The most recent that came in from Dr. Berkland said, you mentioned flexible goal setting. When utilizing participant set goal attainment as an outcome measure, how do you count? How do you account for if the participant changes goals over time? Do you allow the goal to change, or do you have to evaluate the original goal as it was initially set?
Yeah, that's always difficult. We also have that with our COPM, which is the Canadian Occupational Performance Measure, which is also a kind of goal setting evaluation. Well, we start now with our evaluation after the therapist had set the goals, and that is the baseline and not the baseline of the research assistant, because if the research assistant has said, then the therapist is doing more deep interviewing about life stories, and then more or other goals can come up. So that is one thing. Over time, we add goals and we score them as well. So, but then it is possible that we miss baseline for that goal. Yeah. So that is what we now advise. But here, we in those studies I presented, we used the baseline goals and worked on those further on. And we only evaluated those goals. But this is a big discussion in occupational therapy field. It is very difficult because, yeah, and that's why also the randomized controlled trial design is not so nice. Because then you have to stay in that sequence. So, but yeah, it is a way of evaluating that you adapt goals that are important as well or more important, and then use them and take the average, because it is in the Canadian Occupational Performance Measure that you can have 5 goals at maximum, which you take the average of.
That's wonderful. And, in the context of Link AD being a consortium of people for us all to learn from each other across the country, I presume that if Dr. Berkland or others want to get in touch with you and talk more.
Yeah, no problem. You have my email, I hope. Yeah, you can find.
And another question that came up, kind of pointing out the fact that you're really talking very much about pragmatic research. Dr. Abbott had commented, if you're familiar with the RAPT model, and she was curious if you were, whether you had any thoughts about that versus MRC.
The RAPT, and what is that standing for? I don't think I know, but what are the words of the RAPT?
Yeah, Catherine, would you like to go? I think, are you able to go off mute? Perhaps you are. There you go. Yeah.
Yeah, sorry. That's okay. Again, I know we don't have a lot of time, but it stands for Readiness Assessment for Pragmatic Trial Model, and it includes the implementation protocol. It includes evidence, risk, feasibility, measurement, cost, acceptability, alignment, and impact. And so, again, since you're familiar with it, don't want to put you on the spot, but I was just curious.
No, I'm interested. So please send it to me. I'm not familiar with it.
Will do.
Thank you.
Wonderful. Yeah, I think
would be nice if you would present next time about that, because it's interesting. Yeah, thank you.
Well, Catherine just got herself nominated. Okay, maybe if we've got time, there was one more question that came up. Dr. Sheila Maloney. Sheila, you talked about that. There was some comment about adapting recruitment strategies. Do you want to ask your question or comment about that?
Yes, I was just wondering if you could say, thank you so much, by the way, for this very rich presentation. I just was wondering if you could say a little bit more about some of the adaptations that were made to the recruitment strategies with your stakeholders.
Yeah, in the Parkinson trial, I already said that. Perhaps it's nice for the social fit study. We tried a lot of recruitment strategies. Because we needed general people out of the society, and that's difficult because if you talk about problems in social participation, people feel a bit afraid to participate. So we had a cycle, it's Dutch, a cycle, which with how do you say that? where you can carry something in behind the cycle, and you could open it, and chairs came out, and also a coffee corner and things to explain what the project was about. And we stand with that everywhere, on the market, in the retirement homes, at the supermarket, everywhere, and people could come and drink a cup of coffee and hear about. So that was to go really in society, but also we asked, the general practitioners, we asked the geriatricians and the elderly specialists to refer people, but and the home care nurses, which were the most important people who were at home and who knew if people had problems in daily performance, but also in going out, and also social workers. Yeah, so
thank you.
Yeah, but
That's
yeah,
very
we were
innovative.
very creative.
That's
but,
very innovative. If you
still,
serve
it was
coffee, I'll show up.
difficult. Yeah.
I'm sorry, I was just going to help wrap us up. And Jennifer, I know you were here to do that as well. Dr. Graff, though, thank you. It is clear you are an expert across the entire range of research designs and all of the related issues. We're very, very grateful on behalf of the Alzheimer's Association, the National Institute on Aging that funded LinkAD, and I know, of course, great thanks to GSA, and I'll turn it to Jennifer to close us out.
Thanks very much, Dr.
And I
Graff.
would say it's not all designs. There is enough that can be put into it, and other interventions. Yeah.
Thank you both very much. Thank you, Dr. Zimmerman, for taking care of the Q&A for us, and Dr. Graff for such a great presentation. I hope that all of you will join us again next week for our third in this series in collaboration with LinkAD. Thank you so much, everybody. Have a great day.
Thank you for your attention.
Thank you. Bye-bye.
Bye.